Audience is consistently growing, but I think we'll go ahead and get started. I have 7 o'clock. So Shireesha is a very valuable colleague in the ID part of our division. Over the years, she helped me out with many patients, many questions about vaccination, safety, and issues of that kind. So she's kindly going to talk about hot topics in infectious disease in 2024, as you can see. So please go ahead.
Great, thank you so much. I primarily work at Harborview, so know some of you through there. And this is going to be a hodgepodge of things that were highlights of the last year or the last couple of years. I think last time I gave this talk, we were still immersed in the pandemic. But there are other ID issues that I wanted to talk about too, besides respiratory viruses. So word of the day is infection. So the outline today, I'm just going to review updates in respiratory viruses briefly, just two of them, and then talk a little bit about some changing epidemiology and management of STIs, and then review some new antibiotics and some concerning new pathogens. So respiratory viral infections, of course, we're still hearing lots about COVID several years later. Unlike previous years, we've actually, over the last couple of years, seen less of a spike and more sort of this trend towards, I don't want to say normalization, but less high peaks, less mortality, but still, you know, as was predicted with flu, with how it would evolve into sort of a seasonal pattern like the flu, we haven't really seen that yet. There's more frequent increases and upticks in cases than that kind of annual pattern that we see with flu. And so therefore we've seen sort of an evolving immunization recommendations over time. Luckily, over the past year, including over respiratory viral season, we have seen fairly low mortality compared to prior seasons from COVID. And this is from the latest, a couple weeks ago when I downloaded it. Still, Omicron JN1 is now the most predominant variant, but still thought to be susceptible to vaccine. So what's changed is that just recently the CDC changed its isolation guidance. So we had a very prolonged guidance for COVID, 5 days plus a period of post-isolation precautions. And this was really in response to the lack of tools for prevention and for treatment. And obviously that has changed with increase in vaccine uptake, but also that we have oral therapeutics like Paxlovid that is highly effective at reducing morbidity, mortality. May not reduce symptom duration, but it does reduce morbidity and mortality. So the updated guidance is really to put it in line with other respiratory virus guidance in that people should stay home and away from others for at least 24 hours. And after both their symptoms are getting better and they have not had a fever. And that's similar to the flu and other viral diseases that we provide guidance for. And this is a really important change and hopefully leads to less isolation, less loss of days from work, and will have a big societal impact. Of course, there's no change in guidance for healthcare facilities. We are still going to be a lot more conservative to reduce spread from patient to patient and to staff. The new recommendations for a COVID vaccine are that everyone should receive the new updated monovalent mRNA COVID vaccine. This is as opposed to the bivalent, which was used previously. And then just recently, there was another recommendation for people 65 and older that they should receive an additional dose of this updated vaccine at least 4 months following the previous dose of the updated vaccine. And if you've had COVID consider that like the vaccine, to wait 3 or 4 months until getting another vaccine. And this is to really prepare for another spike that we may see in the coming months.
What's the recommendation for masking? It says we seem to be confused, at least I am, in hospital facilities or in public.
Yeah, there's no masking mandate. So there's no, if you've got symptoms and you're in the isolation period, then you should wear mask. But beyond that, there isn't any mandatory masking or masking recommendations. In the healthcare facility, that's going to be very different. If you have respiratory viral symptoms, then you should definitely be masking. Okay, so RSV, this one has been around for a really long time. Why it's highlighted is because there's 2 vaccines that were FDA approved last year, and there's also actually a monoclonal antibody for kids. I'm going to focus on the adult, though. That this is one of the most common causes of respiratory illness. It's the most common cause of hospitalization in infants. Typically in adults, we don't really think about it that much because it's mild or no symptoms, but there are key populations that are going to be at higher risk for lower respiratory disease and potentially hospitalizations. The RSV season starts in the fall and peaks in the winter. Typically, we're already seeing very low cases. We've already had our peak earlier, a few months ago. So here are the diseases that are risk. This is from the CDC that put you at higher risk. This is inclusive of age. So 60 plus one or more of these conditions makes you eligible for potentially receiving this vaccine. And so really any organ disease, any real comorbidities, and 60 and over, you can consider giving this. One important thing to note is that it hasn't really been studied in immunocompromised populations. This is not a live vaccine, though. So last summer, there was a recommendation to use this RSV vaccine. There's 2 types made by 2 different companies. And for 60 and over folks, it doesn't matter which one you get, but there is only one approved for pregnant individuals, which is a different recommendation than the older individuals, which I'll talk about. The data supporting its use are that over a 2-season period, it actually led to less medical visits, ED visits, hospitalizations for lower respiratory disease related to RSV in individuals 60 and over, and this was a multi-site study. So the recommendation that came out was that individuals 60 and over may receive a single dose of RSV vaccine using shared decision-making. This is one of the worst kind of recommendations I think that ACIP can put out, because it puts the onus on the provider to decide and the patient to decide if it's recommended. And the issue here is that I want to underscore, it's not a strong recommendation. Even though there's data there, we recognize that people in general are not going to get really sick from RSV as adults. Who is going to benefit is kids. And there is already a kids vaccine and a maternal vaccine that is aiming at that population. Ideally, if you're going to vaccinate, you vaccinate just before the onset of RSV season. So ideally late summer, so you're protected going into the fall. So the pregnant recommendations are different. It actually is a recommend rather than may give. And this is to protect the babies from severe RSV once they're born. So a single dose, and this is where I was saying there's 2 vaccines, but only the Pfizer RSV vaccine, Abrezvo, is recommended, and that's during their late in pregnancy, so that they make maternal antibodies to pass on to the child to protect them. And this shows a significant reduction in hospitalizations of babies and healthcare visits as well. And that's over the first 6 months of their life. Okay, I'm going to move on from respiratory viruses to sexually transmitted infections. This is just a quick case to highlight some changes and some things that we are new recommendations for managing STIs. So man presents for routine healthcare. He has notes a history of syphilis and gonorrhea, 3 to 4 male sexual partners a month, and inconsistent condom use. Which of the following is most appropriate for him? All right, any thoughts? Not, I don't know, move
I don't
ahead.
know. I'm just going to guess because I don't, I'm going to guess 5. I don't know.
Okay. What I wanted to highlight is a couple of things. Yes, it is 5. We like to offer lots of things for prevention of sexually transmitted infections. One of the things is pre-exposure prophylaxis. And in the past a couple of years, or in the last year, there is now an A1 recommendation by the U.S. Preventative Task Force for providing PrEP. And really what PrEP is, as opposed to PEP, which is post-exposure prophylaxis, is to offer continuously or on demand, essentially. So if there is an exposure, you already have this drug in your system to prevent uptake of HIV and acquisition of HIV. We know that PrEP is underutilized. Only 30% of people are prescribed PrEP who have an indication for PrEP, and there's not equitable provision of it, we know from data from the CDC. So the indications, CDC changed it from more targeted indications to just basically anyone who asks for PrEP should get PrEP, and not really putting up barriers to offering PrEP. Particularly anyone with a recent bacterial STI, partner with HIV who is not undetectable, multiple sexual partners, condomless sex, any exchange or survival sex, or sharing injection equipment. All of these are risk factors for acquisition of HIV. We know that bacterial STIs are common. So aside from PrEP, what can we do to reduce these infections? We're at record high numbers for some of these. Even through the pandemic, we saw a rise in bacterial STIs. And particularly syphilis, we are seeing, I think one of our former colleagues, King Holmes, decades ago thought that we had cured syphilis, that it was no longer going to be an issue. And then the HIV epidemic rose and we saw a rise in syphilis cases. And more recently, we continue to see that rise, even in non-MSM populations. And more alarmingly, we have seen more congenital syphilis as well. And you can see just over the last few years, we've seen a dramatic increase. And we've had a number of cases in Washington state as well. And you can see this from the CDC. In 2012, it was 335, and now we're close to 4,000 at the end of 2022. So there is a new way to prevent bacterial STIs, not just PrEP for HIV, but there's a pill that you can take like a morning after prevention of STIs, and it is doxycycline. And doxycycline has been around for a long time, use it for lots of things, but now there are a number of studies that show that doxy post-exposure prophylaxis that's given within 72 hours, ideally within 24 hours after condomless sex, can prevent acquisition of STIs. And you can see here the early data was actually close to a decade ago from the Ipergay study, which was actually looking at HIV pre-exposure prophylaxis, but they offered doxy post-exposure prophylaxis, and there was a relative risk reduction of almost 50%. Since that time, we've had doxy PEP, which is a study that we did here at the Madison clinic where I work, as well as at in San Francisco at UCSF, which showed similar results, a greater than 50% reduction in bacterial STIs. And then there was also a French study looking at this, which showed an even higher percentage of reduction. Unfortunately, this last study was DPEP, which was the only one that focused on women, cis women in Kenya, which did not show a reduction in infections. And a lot of thought about what that means. We know that early PrEP studies for HIV also had similar results in women in sub-Saharan Africa. So more to come on women and the role of doxypep.
Is that all organisms? We're talking gonorrhea, syphilis?
So it's
just across the-
gonorrhea, syphilis, and chlamydia. The biggest reductions are really in chlamydia and syphilis. But even though there's resistance, gonorrhea is predominantly resistant to doxycycline, we still see a benefit of a little less than 50% for gonorrhea reduction. So it's basically just taking two doxycycline, so 100 milligram capsules or tabs, and within 72 hours of any condomless sex. And it can be offered to any, it's mainly MSM or transgender women with any history of bacterial STI. These are draft recommendations that have not been finalized yet. These came out in October, and we expect final guidance to be similar. And this is not a must offer. This is should be offered or considered, should be considered. It is not currently recommended for cisgender women, cisgender heterosexual men, transgender men, or other queer non-binary because the data is insufficient. We may see some additional data come out and some broadening of these recommendations over time. And this is just part of a whole package of interventions. Like I mentioned, for this gentleman, all of the above was the answer because there's lots of things that we can do. Routine STI testing, making sure to test for HIV and offering HIV prevention, and doxypep is part of that armamentarium of comprehensive sexual health. There are some unknowns about chronic use of doxycycline. There are other indications where doxy is used chronically, for instance, acne, and so our dermatologists use it quite a bit, but one of the things that we counsel about is just some potential side effects. And then we don't really know the development of antimicrobial resistance. There were some data presented just earlier this month at the conference for retroviruses and opportunistic infections that showed, at least a couple years into the study, there was no change in flora and increased antimicrobial resistance. And then here's just some other things that it doesn't actually protect against all STIs, so really important to consider that. And like I mentioned, routine testing is important. Okay, switching gears, there's a question here in the chat, so I wanted to, yeah, I think that antimicrobial stewardship, we're still learning more. And then a question about not well covered by insurance. Yeah, I did, so this is an issue with the way, the benefits for these, because most of the patients are Medicare, that it can't be given in a clinic. It's really, you got to go to a pharmacy to get coverage. If it's given in a clinic, it won't get covered. And so there's been issues about operationalizing this vaccine. We actually don't give it in our clinic. We send it out to a different pharmacy or a discharge pharmacy at Harborview for it to be covered and for the insurance to run through. All right, I wanted to focus a little bit about some multi-drug resistant organisms and some new and potentially old antibiotics, just so you're familiar with them, because there's lots of people with antibiotic allergies that we as ID colleagues send to you all, and just for you to have a sense of what these drugs are and their niches for use. For a long time, we didn't have anything for resistant gram negatives. We just had stuff for resistant gram positives like vancomycin or linezolid. But over the last few years, the pipeline for drug development for resistant gram negatives has actually been a little bit more robust than it had been in the past. These are bad players. Extended spectrum beta-lactamase producing organisms, carbapenem resistant Enterobacteriaceae or Enterobacterales. We don't see this much. Those of you who trained on the East Coast or came from the East Coast probably saw a lot more carbapenem resistant organisms. So carbapenems being our imipenem, meropenem, ertapenem. And we like to limit that with our infection prevention strategies. Then there's difficult to treat Pseudomonas aeruginosa. This is kind of a new nomenclature instead of MDR, Pseudomonas aeruginosa, but these are essentially multi-drug resistant Pseudomonas. And then carbapenem resistant Acinetobacter. We've seen a significant decline in our carbapenem resistant Acinetobacter over the last few years. Most of our Acinetobacter, at least at Harborview, is actually pretty susceptible. Also at Malt Lake, we have had outbreaks of more resistant Acinetobacter. There was some a decade or so ago from returning veterans who came from the Middle East, where we were seeing significant resistant Acinetobacter colonization and infections. So I'm going to focus on the CRE and DTR just because of some drugs that have come about. So here are the new antibiotics. Some of them have been around for a couple of years, but you may not be that familiar with them. Ceftolozane, tazobactam, ceftaz-AV have been around for a few years. Imipenem relebactam. Really what these bactams are really trying to fight against the beta-lactamase producing aspect of the bacteria. So by pairing the antibiotic with something that's going to break down that beta-lactamase. And then meropenem vaporbactam is a newer one. Cefiderocol, which you're probably going to hear more about. This is going to be our Trojan horse of antibiotics. It can do a lot, and it's a relatively new kid on the block. Plazomicin, and then eravacycline. So there are some older antibiotics also being called into action, some aminoglycosides, polymyxins. We've been using those a lot less with the advent of some of these newer drugs, just because polymyxins are really not well tolerated in terms of their toxicity profile. And then tetracyclines and amsulbactam have a potential role as well. So in terms of our ESBLs, I just wanted to let you know that they are enzymes that inactivate most of our penicillins, cephalosporins, and astrazeneam. So it can be produced by E. coli and some Klebsiella and Proteus. They're not routine testing done, but there is, you can tell on the susceptibility patterns if there's ceftriaxone resistance. It is a proxy. Our lab does do ESBL testing, but many labs don't. In terms of carbapenem resistant Enterobacteriaceae, we've had a steady number of cases, potentially an increase in the last part of the last decade. And really not seeing as much, like I said, in our neck of the woods, and we'd like to keep it that way. Difficult to treat Pseudomonas infections. Actually, there has been a little bit of a decline in those. These are going to be more common in people that have a lot of healthcare exposure, just like any of these multi-drug resistant organisms. And really what we need is good tools for this. Difficult to treat is defined as essentially non-susceptibility or resistance to all of these things, which are our usual drugs that we use to treat pseudomonal infections. So ceftolozane tazobactam, it's actually a new cephalosporin with an old inhibitor. And so like I mentioned, this combination to overcome the inhibition or the protective mechanisms that the bacteria have created. Most of these drugs are going to have an indication for UTIs or bacterial pneumonia, because the other indications for which we use them for are going to be a little bit harder to test, like bacteremia, for instance, or more other deep-seated infections. The activity is not uniformed. It's given through a prolonged infusion. There are some limitations of this, but we can use it for difficult to treat Pseudomonas aeruginosa infections, and that's kind of been our go-to. Ceftaz-AV, it's an older cephalosporin with a new inhibitor, so kind of the switch of the other one that I just talked about. It's similar to other beta-lactams in terms of their susceptibility. Avibactam is only inhibitor. By the way, there's no actual antibacterial intrinsic activity. And it doesn't inhibit some of our more complex resistance mechanisms, like the metallo-beta lactamases, which we don't see very much here, and we worry about in people who come from other countries to the US. And obviously all of these are IV only, and this has a niche for difficult to treat Pseudomonas, as well as carbapenem-resistant Enterobacterales. Okay, so meropenem, this is an old carbapenem we've had for a long time and a new inhibitor. It's only FDA approved for UTI, but we don't really use it for UTI. We use it for all the other things off-label that are more serious infections. We don't have this currently available on formulary at UW, but it is available for use as non-formulary as needed. Again, the inhibitor doesn't have any intrinsic activity, and it is new, so we don't really have as much data for its use in these more serious infections, but potentially a role for treatment of carbapenem-resistant Enterobacterales. And really, even though meropenem is a carbapenem, the vaborbactam overcomes that resistance mechanism. Immirelli, similarly, imipenem we are all familiar with as an old carbapenem, and then another new inhibitor. And again, relebactam doesn't have any intrinsic activity. And then it has the indications for intra-abdominal infections, UTI, and bacterial pneumonia. We've used it a couple of times at Harborview and at Montlake, and there's some growing evidence for its use in more serious infections, particularly for CRE and difficult to treat Pseudomonas infections. Obviously, from an allergist standpoint, if you're allergic to any of these components, then we have to think about other options for people. This is a potential one that is a novel cephalosporin and has a different method of entry into the cellar, and it's structurally resistant to the resistance mechanisms that bacteria have created with the beta-lactamase. So it doesn't require a beta-lactamase inhibitor like the other ones I mentioned. We've used it a few times. That's what I mentioned. It's sort of the Trojan horse. It's in our back pocket for things that are really resistant, for which we don't have a lot of options for, and we know that standard resistance mechanisms of porin and efflux mechanisms of resistance don't actually impair cefiderocol, and it's able to circumvent a lot of these, and so it's a real game changer for some of our patients who have really resistant infections. It's quite costly, unfortunately, and it has to be given frequently IV. So there's going to be some issues in terms of operationalizing its use outside the hospital. But lots of uses here, pretty much all of the ones that I mentioned before we can use cefiderocol for. Aminoglycosides, we're all familiar with aminoglycosides.
Before you go on, can I just ask you, as someone who's, most of these drugs you just talked about, I'm not familiar with, is there anything more you can say about their cross-reactivity with other beta-lactams as far as allergy?
That's concerning to me too, because we don't have a lot of data about these. Some of them, I would say, the older cephalosporins and carbapenems that we already know about that are paired with new beta-lactamases, this is like the Immirelli. If you're allergic to imipenem, then that's not going to be a great choice. In terms of the cross-reactivity of the cephalosporins like ceftolozane, I don't know actually structurally if that's going to be that different than the other cephalosporins. Ceftaz, that's already been around. You're probably already familiar with that cross-reactivity though. And so if they're allergic to Ceftaz, then Ceftaz AV would not be an option. But in general, carbapenems are not as cross-reactive, correct, with the cephalosporin. So if you've got somebody with a cephalosporin allergy, then you could use like imirelli. Cefidoracol, it's structurally very different, but I don't have any knowledge about its cross-reactivity with other cephalosporins. Are any of these available outpatient? So they're all IV, and so they're challenging to obtain an outpatient infusion setting. We have done it for a few, but most insurance companies are going to say it's way too costly to organize. And so like Cefidoracol, we weren't able to get our patients, so they stayed in the hospital for 4 weeks to complete their therapy. So these are a bit challenging for patients who need long-term treatment, that they're going to need to be in the hospital for at least some of these antibiotics. And most skilled nursing facilities are not going to put up the cost because they get a fixed they get fixed payments, and so these meds are pretty costly. Okay, so we know aminoglycosides. They've been around for a really long time. We don't use them, nephrotoxicity, ototoxicity, but they do have some potential benefits to use for some of our patients with more resistant infections. And there is a new aminoglycoside on the block called plasmicin, and it's got some modifications that get around some of the conventional aminoglycoside resistance mechanisms. As with most of these new ones, they're got their label indication for UTI, but that's not what we would use it for. But the data is really just in a UTI right now. There's a phase 3 study ongoing, but then there was one that failed due to too small numbers. So we don't actually have this on formulary. We're not quite sure of the niche that it offers, in addition to all the other new or newer gram-negative targeted antibiotics that I just presented. Phage therapy. So I just wanted to throw this out because it sometimes gets thrown out at our conference about how we can do this. We don't have this available here. There are other institutions that do. There are a lot of logistical operational issues involved in offering phage therapy, but this is something that we want somebody to take on, I think, in our division, if somebody is interested. Bacteriophage are viruses that infect bacteria, and they're very targeted, and it's bacterial killing through infection replication within the bacteria and eventual bacterial lysis. And so really sophisticated in a way, and hopefully we'll see this more used. There have been a handful of cases that people have been referred for phage therapy, but like I mentioned, there's a lot of logistical issues to go through. Okay. I wanted to talk a little bit about some new priority pathogens. I didn't really talk about fungi, and I kind of want to make this broad: viruses, bacteria, and then fungi here. Here's the WHO priority list, and you can see here Cryptococcus neoformans, Candida auris, Aspergillus, and Candida albicans are at the top of the list. Cryptococcus neoformans is something that we see typically in fairly immunocompromised individuals. So people who have advanced HIV, for instance, this can become a disseminated disease that involves brain or lungs. We can also see it in immunocompetent hosts. We actually have a Cryptococcus neoformans variant Gaddii that some of you may be familiar with, that was up and down the upper West Coast here in Washington and off the coast of Vancouver Island several years ago, that we saw increase in cases, and we still see a smattering of cases of that organism. Typically, it's going to be lung disease in those patients, but we have seen even bone infection and other disseminated sites. Aspergillus fumigatus, that is a ubiquitous mold, and we don't really see infection from it except in people who are immunocompromised hosts. So that's our patients with prolonged neutropenia. So on our stem cell transplant services. We'll see patients with aspergillus, and that can go anywhere essentially. Candida albicans, also ubiquitous, also part of our flora commensal, but can cause more invasive disease in immunocompromised hosts. Again, our stem cell transplant population, where we can see candidemia, we can see disseminated sites in the spleen, in the liver. In patients with HIV, advanced HIV, we can see more mucosal involvement, like esophagitis, that can develop from Candida. So lastly, Candida auris. So I'm sure people have seen Candida auris on the news, and I'm going to talk about that a little bit just to keep you up to date, especially because we've had some cases, one very recently at Montlake that wasn't infected in our area, but was an imported case, and kind of the implications for screening in our community. Oh, there's a question about probiotics playing a role. You know, I'm not sure that probiotics will necessarily have a bigger role in supportive treatment of MDROs. There are roles for probiotics in prevention of antibiotic-associated diarrhea, and some data for modest data for prevention of C. diff, but I'm not aware of support of treatment in MDRO. Okay. All right, so what is Candida auris? It's another Candida yeast species. Auris comes from the name ear, where it was first cultivated from an ear swab. And then a little while ago, not that long ago, it was first identified by Japanese investigators. But since its identification has arisen from multiple sites globally, and now it's present in the United States since 2015. And why do we care about this Candida as opposed to all the other Candida that are around? It's because there's high levels of resistance to azoles, and sometimes also echinocandins and amphotericin, which are our main armamentarium against Candida. And it's actually really hard to kill in the environment. So not only is it hard to treat if somebody gets an infection, it's actually also hard to eradicate in the environment, which can be a real setup for outbreaks, and particularly in hospitals that have immunocompromised patients like ours do, where you can get serious, hard to treat infections. So where did it come from? As I brought up in last year's talk too, there are a lot of things that come up through global warming, lots of things that we didn't think that we would see in the United States that we are seeing, like leishmaniasis, that is, in Texas and Florida, malaria. These things are now becoming part of our world in our country, as opposed to something that we see in travelers or someone from other more endemic areas. So there have been a change in the sort of environmental flora, and fungi that used to thrive in more tropical areas are going to be in more temperate climates. And so, sorry, let me just move this bar. Candida auris was that basically through climate change, it gained some of its resistance and tolerance to environments, and so making it a little bit harder to eradicate. It was probably transplanted by birds across the globe, even to places where there was, not much there before. And then rural activities such as farming led to interspecies transmission of these more virulent pathogens, but also some of these resistant mechanisms that were shared. And then it was migrated towards human environments, urban environments, like where our hospitals are. It's a global threat. It's been in the news a fair amount. We don't know why there are these 4 strains of Candida auris that emerged around the same time across the globe. Like I said, all 4 strains have been found in the United States, and they were probably introduced through international travel and then subsequent spread through healthcare facilities. But you can see here that there's this regional, so in India, there's this strain, and you can see sort of they're separated, but in our country, we have all 4 of them. Not anything in Washington state yet. It can be spread through person-to-person contact, direct contact, and environment to person via direct contact. So things that are on surfaces, and it can persist through on surfaces. So that is the issue, in that long after a patient has been there with, or a person has been there and they have Candida auris, it can still be on the surface. It's not thought to be transmitted through airborne or droplet. And it's not a select pathogen, meaning it's not one of those where we take, a high level biosafety level sort of precautions. Where does it cause infection? It can cause infection anywhere. And again, this really depends on the host. So it can cause central nervous system infection, candidemia, it can infect the heart through endocarditis, eyes, endophthalmitis, osteomyelitis, and it can go sort of to any other organs that it can spread through hematogenously. You can, and you can also be asymptomatic skin colonization as well. The chronically ill patients are going to be at the greatest risk for mortality, and there's been a case mortality rate of 30%. So very high in patients who have ventilator-associated pneumonia with Candida auris or candidemia or endocarditis or meningitis. And you can see here over time, from 2015 to the end of 2018, the dramatic increase in Candida auris, actually cases of infection in the US. So 90% of isolates of Candida auris are resistant to at least one antifungal. And so that's very stark contrast to our Candida albicans, which is almost always fluconazole susceptible. And then 30% of isolates are resistant to at least 2 antifungals. So when we've got something this ubiquitous, this resistant to clear in the environment, and then with the potential for significant mortality that's got this high of a resistance, that's why we people and infection prevention people, infectious disease docs, and everybody should be really concerned about the outbreaks of Candida auris. Or just this month, UW and Harborview started screening for Candida auris, just because we've had 2 cases, although one was just colonization and one more recently infection, both imported. We do want to be really cautious about it spreading into our community. So what can we do? Early detection and infection control can limit the spread of Candida auris. Like I just said, we've just started implementing that in our system. So in terms of Candida auris, it's resistant to most azoles and sometimes echinocandins. And echinocandins are like our mica fungin, caspofungin, and newer resifungin. It spreads person to person. And then really thinking about when to screen, what's the threshold to screen in the population. And right now that has been met here for the most part, at least for now, because of those 2 recent cases. And it can be hard to identify. And that's another aspect of it, particularly in critical access hospitals where they may not have as strong of a microbiology or lab presence like we do. And then prevention is critical. Right now, echinocandins for the most part work. Then in just overall, my take-home points for MDR infections are to de-escalate antibiotics when possible, because we don't want to lose these options for treatment. These are brand new. We don't want to blow them all right now. And these bacteria are super smart. And so using them for longer doesn't mean better. And actually, most of the literature for treating infectious diseases is showing that shorter periods of time is actually fine. No more of these 2-week durations. Much of our bacteremia cases, like even gram-negative rad bacteremia, we can treat for shorter periods of time, like a week. MDR infections are challenging, but there's going to be more resistance. These bacteria are going to come up with more things to make us work harder to get different antibiotics in the pipeline. So that's it. And I'm happy to take any questions. I know it was kind of a whirlwind of lots of different hodgepodge topics, so I wanted to leave some time for questions.
Thank you very much, Shireesha. I had a question about respiratory syncytial virus. So through most of my career, we never really talked about this as an infection of adults. It was something we just talked about in young children as a risk factor for developing asthma. Initially, we thought early childhood infection with it was strongly linked to development of subsequent asthma. One question, I guess, when did we start to realize that it could be a serious infection for people over 60? And how did we go about developing vaccines so rapidly?
Yeah, these have been in the works. The vaccines have been in the works. And, definitely targeted towards the maternal population. Because of as you mentioned, this is really a disease in young kids when we see more severe or serious outcomes. However, in the last several years, when we look at respiratory virus infections and hospitalizations, there is actually a increase in patients with underlying lung disease, heart disease that are older that are getting admitted or dying of RSV. And so that is why over the last few years, we've really seen this push towards even opening up that recommendation. I think it's always been a concern in children, and the development of these vaccines, in particular, Pfizer wanting to have the maternal vaccine indication was really critical, because that's where I think we're going to move the needle for overall health in that pediatric population. Now, I didn't mention this because I'm more of an adult doc, but I know that some of you see children, is that there is a monoclonal antibody that can be given to children early on to protect them during RSV season if their mom didn't get vaccinated. And so this being the first season last year, many moms had not been vaccinated. And so catching up with the kids by giving them this monoclonal antibody that's considered a vaccine was actually critical to keep those kids healthy. Over time, we may see less of that use, particularly if mom is in prenatal care and getting this vaccine. And so I think that's where we're going to really see a public health benefit. As we did with pneumococcal vaccination and introduction into the pediatric population, we saw a dramatic benefit, even as an indirect benefit in adults, even in older adults, because the kids that they were around, the babies they were around, did not have RSV. So that is the hope, that we will be able to have not only a direct effect, but probably an indirect effect as well. But I think it's really because there's a recognition that it isn't zero impact on adults. There are adults who are vulnerable, who can get severe RSV disease.
I know there are a number of things in the chat. I don't know.
Oh yeah, PrEP utilization in adolescents and young adult males. Yeah, that is a target population that we need to do better about. And there are lots of really interesting strategies to target this population. Because I just saw an acute HIV infection, and he's 19. So really want to try to get people educated about it. And he actually didn't even know about PrEP. He didn't know that there was a medication that could prevent HIV. So targeting messaging and then lowering the barrier. We actually have direct pharmacies that actually offer PrEP. So one in our area is Kelly Ross. People don't even need a doctor's appointment. They can just go into the pharmacy and get pharmacy-driven PrEP. And there's it have a CDTA, meaning that they have a provider that kind of oversees the program, but really trying to reduce barriers. There is also PrEP by mail. And so if people don't want to go see a doctor, they can do the testing at home, mail in the kit, and get their PrEP from home. And there was actually just a news article about this because the CDC had this pilot program and it was very successful for offering mail order PrEP. So I think we're going to see more programs like this. Most young people that I see don't need to see a doctor regularly, and coming in every 3 to 6 months is just, seems like unnecessary to them. And so ways that we can be more creative to target that population are going to be important. Also, women are less likely to take PrEP, even those at risk. And so one of my jobs is I founded a clinic on North Aurora called S.H.E Clinic, stands for Safe, Healthy, Empowered. And it's for women engaged in survival sex on Aurora. And it's run out of a nonprofit day center where these women were already coming for food and other kinds of support. And when we started in 2018, none of them had heard about PrEP. And at the same time we started, there was a cluster outbreak of HIV of 9 new cases in women. And we diagnosed some of those women, and they had no idea that they were at risk for HIV. And so even despite of that, they are still on their hierarchy of needs. PrEP is still quite low, and they still don't think that they're at risk. And so there's still a lot of education and a lot of different types of strategies that we can use. There's going to be some new long-acting PrEP. There's one already that's 1 shot every 8 weeks. And there's hopefully going to be one that's 1 shot every 6 months that is coming up. That is going to be it's going to be a game changer for some of these individuals, particularly the young people who don't want to take pills every day.
I have another RSV question.
Yeah.
In vaccinations in the older people, I noticed that the protection wanes over time. Is there any plans on repeating it after 2 years or seasonal?
Yeah, I think there are going to be some modified recommendations. So this is, this was a permissive recommendation of may consider giving to this population. And I think with some real world data, and we're going to see a modification of that recommendation to either a stronger recommendation, and then also the interval at which we should repeat. The data from the study, like I mentioned, was over a 2-season period where it was felt to have a benefit. Beyond that, we don't know. And I anticipate that it would be a waning just based on the trajectory from the first to the second season. And so I think we're going to see some potential longer term data from the vaccine manufacturers supporting a repeat dosing for some individuals. But that's kind of unknown right now.
Thank you.
Any other questions? Certainly, I don't know, I can speak for other people, but for our allergy society, tremendous changes in ID, a lot of things extremely valuable, keeping us aware of what's going on in your specialty.
Well,
any other
thanks.
comments that you would make that bear on allergy specifically that you've come across with newer drugs? Anything that would interface between our two specialties?
Yeah, I think that one of the things is what one of you brought up is that we don't really know with a lot of these new antibiotics, and there's going to be, I would look to you to kind of help with sorting out which ones are safe to use in the setting of people with prior beta-lactam allergies, especially for our patients who have very limited options for treatment of their multi-drug resistant organisms. So I'm going to look to you all as the specialists for that. One of the things that has definitely come about that we've been working with Lily, and who's been great at Harborview, great addition, is our patients. We have a lot of syphilis right now, a lot, and a lot of people with purported penicillin allergies. And so it's been really great for us to have that access to dispel some of these allergies so that we can use, first line therapy for all of our syphilis and neurosyphilis infections that we're seeing. So thanks, Lily.
All right, well, thank you again for an outstanding presentation. Lily, I think Lily is responding that she's been helping you with the testing on these people, so thank you. Any other comments or questions? Well, thanks everybody for getting up early this morning. Angela, thanking you for a great presentation. I fully agree. So the problem is if you give a great presentation, we're going to ask you to do it next year, but there'll be new issues next year.
Oh, I think though we're going to be done. I'm going to be out of a job, right? There won't be any more infections.
Yeah, right. Okay, thank you again.
Thanks.
Bye-bye.
All right. Bye, everyone.